the selection bias as well as the information bias. So for cases, the question is, are the cases which you have selected in the sample representative of all the eligible cases? And are the cases with exposure more likely to be selected in the study population compared to cases without the exposure? These are the two questions which you should ask. If you're reading a case control study or if you plan to perform a case control study, these are the two questions which you should try and answer, which help you to rule out bias. So what do I mean by this? You can see that on the topmost left hand side, what you see is the situation which is there in the population. So you have cases and controls and the exposure status. And if this is the condition, actually there will be no significant difference in the exposure status between cases and controls. But when you are selecting, if you are selecting more cases who are exposed in your population, there will be a wrong, there will be an overestimation of the association between exposure and outcome. And you will go away from the truth. So how can this occur? So you have this example in which you have the research question as, does diabetes mellitus increase the risk of SARS-CoV-2 infection? And it could be say severe infection. So that actually what you are interested is in all lab confirmed COVID-19 infections. I think what I'm looking at is COVID infection. Now, but what I do is I say from the point of view of feasibility, I say, okay, let me just look at the hospitalized patients. So I recruit only hospitalized COVID-19 patients. But we all know that people with diabetes mellitus are more likely to be hospitalized, and therefore your cases are going to be not representative of all the COVID-19 infections in the community. And on top of that, so there is over-representation of diabetes mellitus in your cases. And if you decide to take population as a control in this case control study, then you are going to inflate the odds ratio or the association. You're going to overestimate the association of diabetes risk and COVID-19 infection. Are you getting me here?
Yes, ma'am.
So what happens, that box which was there for diabetes. So in this previous example, this box which is there, this box you have increased by taking hospitalized patients because you are more likely to get diabetes mellitus and COVID-19 if you just focus on your hospitalized cases. So you are increasing this box, and by doing so, you are overestimating the association between diabetes mellitus and COVID-19 infection. So one of the participants has said that they are interested also to know how to prevent bias. So all these yellow colored boxes in each slide are going to tell us how to avoid and prevent such biases. So instead of saying I am going to stick to hospitalized patients, the right way to conduct this study would be to look at either all or a sample of all incident lab confirmed cases. And if we want to still, because of limited resources, if we still want to do your hospital-based case control study, then what happens is you have to ensure that cases and control come from the same source population and all of them have been tested for COVID-19. Because when you say that routinely in the routine hospital system, when all are tested and you have people who are positive and negative, it means that all these patients have gone through the same care seeking pathway and testing pathway, and they are comparable to each other. So doing a hospital based study is always challenging, but you have to ensure that your cases and controls are comparable in ways except probably their exposure. So if you are saying I want to look at infection per se, I have to really take into consideration not just hospitalized cases, but all lab confirmed cases. Now, another important bias which occurs in case control studies when you're selecting cases and is when you select prevalent cases, right? So this is also known as Niemann bias or Niemann's fallacy. It is also known as incidence prevalence bias. Now, what happens is that prevalent cases, if you just say that I'm going to take prevalent cases, all cases, I'm going to do a survey and all patients who are positive or who have the disease I'm going to recruit in my study, only those who have survived up to that particular point or who have disease up to that particular point are going to be included in your study. Now, as an example, supposing you want to find out, do women have a higher incidence of long COVID than men? I'm sure you have heard about this concept of long COVID. Can anyone just tell me what this long COVID means? We all thought that COVID was an acute infectious disease, but we know that there is evidence that even after recovery from the acute phase, the symptoms have persisted and people are still suffering for months and years together, right? So we want to see whether this phenomenon is more common in women compared to men. So in the study, the investigators, they recruit all the prevalent cases of long COVID in a particular point in time, or say in a particular point means it could be even say a month or a few months. And among them, they find out what is the distribution of men and women, right? Compared to those who do not have long COVID. Now, what will happen in these cases is that if men have higher post acute mortality, they have died earlier, and you are just recruiting prevalent cases, fewer men will be available to be recruited in your sample. So, you will wrongly make an inference that long COVID is more prevalent in women. So to prevent this kind of bias, you have to, this is another important realization that in case control study, you need to recruit incident cases. What does that mean? It means the cases which have been recently or newly diagnosed. So if you recruit incident cases as cases in your case control study, you will prevent this Niemann bias. And when you then recruit incident cases, means what? You recruit a cohort of COVID infections, acute infections, and you follow them up. So you do a cohort study instead of a case control study, or you do a nested case control study. And you should be, if you're doing a cohort study, you should use time to event method, and you should calculate cumulative incidence of the long COVID, because the men and women are going to contribute different periods of time in your study. Are you getting me here?
Yes, ma'am. Yes, ma'am.
Yes, ma'am.
If you do a cross sectional, you say, okay, I do not want to do, I cannot afford to do a cohort study. Then if you do a cross sectional study, you have to interpret your findings as prevalence and not as incidence. And you have to mention your limitation in your discussion section. That is also okay, but this important limitation, that survival could be different in the two groups and that could contribute to the differences, is what you should not forget to mention in your discussion section. Another important point I want to make is that when you are looking at selection bias, an important thing is that when you have an exposure and an outcome, here it is the sex and long COVID as the outcome. What is the fact is that your prevalent cases are the ones which you are recruiting, and this prevalence depends upon the survival of the person up to the point you are recruiting the individual, and only those who are surviving are going to experience long COVID. So when you have this kind of relationship where indirectly your recruitment is associated with the outcome as well as the exposure, that is the time when selection bias occurs. So you have to ask yourself that this recruitment or retention, is it some way affected by exposure as well as outcome? If your answer is yes, then you have to really start thinking about selection bias. I'll talk about this in detail in the upcoming slides, but I just want to introduce this particular triad or concept here. The next thing which comes up is, I uttered the word Niemann fallacy. So there is a subtle difference between bias and fallacy. Do you remember anywhere else you have heard this word fallacy?
Ecological
Ecological
Correct. So
fallacy.
it's there in this slide, SMART group. So bias, I'm saying, is a systematic error in the study design or in the execution, which leads to distorted estimates. But fallacy is not an error. It is just a problem in your interpretation or reasoning or your logic, which you are making in your study, right? So it is an incorrect inference you're drawing. Like in your ecological fallacy, you are working on a group, and if you say what is true for the group is also true for the individuals, that is a problem with your interpretation. So that is a fallacy, which are errors in logic and interpretation and not errors in design. So this Niemann fallacy, it is called as a fallacy because if you are studying prevalence and if you stick to the word prevalence everywhere, it is not a bias. It is, but if you say incidence instead of your prevalence, still it is not a bias, it is a fallacy because you are making an error in interpretation of your results. So this is something which you should remember. Many times you will see the word fallacy, it means there is a problem with your interpretation. The next thing we are going to see is, okay, we have seen there are problems in selection of cases, but there can be problems in selection of controls too. So what are these problems which we are looking at? So control, if a control had the outcome of interest, they would potentially have been included as a case. This is one criteria for your control. So as an example, the what I'm trying to say is that these controls should be susceptible to the outcome, and if they would have had the outcome, they would have become your cases. So those people you're going to take as a control. Another criteria, controls should be representative of the source population, means the population from which your cases have come. Controls must represent the exposure distribution in the source population. Now, this is another thing which you understand, that why you are comparing your cases with controls, because you want these controls to be the ones who will tell you what kind of exposure is there in the population which produce the cases. And if the cases have substantially different exposure experience than the source population. So your controls have to represent the source population with respect to exposure. And another point for control is that it must be independent of the exposure. You should not know the exposure status, and your selection of the control should not be influenced by the presence or absence of the exposure. So when you are planning a case control study or reading a case control study, you should ask whether all of these criteria are being met for the controls. Again, this particular part is what is the situation in your population. And when you are selecting, supposing you select more people who are exposed, more controls who are exposed, what happens in the population? There is a true association, but because you have over representation of controls who are exposed, there will be an underestimation of this association. So you will find a weaker or no association between exposure and outcome because you have a problem in selection of the controls. Now we are going to look at an example. So example is, the question is obesity a risk factor for severe COVID-19? Now cases are those who have severe COVID-19 admissions, and controls are individuals with coronary heart disease. Now, we all know that obesity increases the risk of CHD and hospitalization because of CHD. So here, in controls, there is over-representation of the exposure, that is obesity. And because of this, your odds ratio is going to be underestimated or is going to be biased. If you want to prevent this bias, you have to consider the hospital controls with diseases which are not related to obesity. We all know that CHD and obesity are related to each other. And if there is an association between obesity and severe COVID-19 admissions, this comparison is going to downplay that association. So then you have to take something like trauma or acute appendicitis or any other entity which is not related to obesity. And of course, all of these controls need to be tested, and you have to ensure that they are not suffering from COVID-19. So same source and same testing pathway is another criteria. So sticking to the same hospital because it has a particular system of admission criteria and method, and identifying a disease which is not related to your exposure is what you have to ensure to prevent this kind of a bias. So again, you have to ask, okay, my selection, that is my hospitalization, because I am going to take hospitalized individuals. So directly or indirectly, if it is associated with obesity and with severe COVID, the exposure and outcome, then yes, this has a potential to bring in bias in your study. Now, this was about case control study. Did you all get me with regards to case control study?
Yes, ma'am.